As we go on with the webinar, please send in your questions for our panel. So I'm going to pass the time to Rob Davies now.
Thank you, Patrick. And we do truly have an international faculty today, and I'm just going to run through their biographs to give the attendees a good view of what they can expect from their talk. We have Ruth Benson, who's an academic clinical lecturer in vascular surgery at the University of Birmingham Clinical Trials Unit. She's completing her training in vascular surgery as well at the University of Coventry and Warwickshire. She's a past president of VERN, which is the Vascular Endovascular Research Network in the UK, and an associate specialty lead for vascular surgery at the Royal College of Surgeons of England. So we'll get a very good UK-based view of the condition today. Second up, we have Robbie George, who is Chief of Vascular Surgery at the Narayana Health City in Bangalore, and Associate Editor of the Indian Journal of Vascular and Endovascular Surgery. He's a founding member of the Asian chapter of the International Society of Vascular and Endovascular Surgery as well. So that will be a very interesting talk from Dr. George. Third up, we have Max Wohlauer, who's a vascular surgeon at the University of Colorado, Anschutz Medical Campus, and medical director of the Vascular Diagnostic Lab. He co-founded the Vascular Surgery COVID-19 Collaborative, which is evaluating the impact of COVID-19 on the care of patients with vascular disease. So we have a true expert in the impact of COVID on vascular surgery from our United States of America colleagues. And finally, we have Christian Alexander Behrendt, who's a consultant vascular surgeon at the University Heart and Vascular Center in Hamburg, where he is clinical lead for peripheral bypass surgery. He chairs the German Vascular Registry and co-chairs the ESVS Clinical Practice Guidelines for PAD. He's also the chair of the VascuNet, so look forward to hearing a German perspective on the condition as well. During the talks, we encourage question and sessions or questions being written through the chat function, which the panel and the chairs will address as we go along, as well as pick up on the salient ones at the end of each lecture. We've also got some polls to go along with, and I'd like to introduce the first poll just before we go into Ruth Benson's talk. The first poll is really to get an idea of what's going on out there at the moment from the attendees. And specifically, it's whether or not the volume of patients with or without COVID-19 presenting to your unit with acute limb ischemia has indeed increased or stayed the same during the pandemic compared to the pre-pandemic period. So if we can just ask the attendees to quickly go through that, we'll just take a snapshot just to get the session going. At the moment, yeah. So 2/3 have answered. If the final third just want to type what their views are. Interestingly, it seems to be suggesting that people believe that it has increased. In Leicester, from a personal perspective, we've been in effectively lockdown since day one of the COVID pandemic. And our personal experience is, anecdotally this is, we don't think the actual overall incidence of acute limb ischemia has increased, and we haven't seen huge numbers as a result of COVID-19 specifically. So we seem to be perhaps more of an island of experience compared to what the attendees are. Okay, those are the results. I don't know what your experience is from down south, Patrick, at the moment. Would you say that reflects your experience as a unit, or?
I think sadly we've lost a lot of limbs down south. Maybe it's our unit, but yes, I think that we've been sadly losing a lot, doing lots of amputations.
You think that's from ALI or just progression of CLTI that hasn't been picked up due to the facilities not being readily available during the pandemic?
I think a combination, and I think without looking into the figures in detail, but yeah, we've seen a few sort of very unusual cases with young, relatively, healthier 40, 50-year-olds with sort of complete aortic occlusions, etc. So,
interesting. I mean, talking to colleagues just 30 miles north of where we are in Leicester in Nottingham, they say they've seen a fair number of acute thrombotic episodes, and it just doesn't seem to be panning out that way in Leicester, thank God.
Yeah.
So moving on from the poll, we're going to introduce Ruth Benson, who's going to be discussing the sort of the UK-based experience. So Ruth, thank you for agreeing to participate, and we look forward to your talk. Over to you, Ruth.
Thanks very much for having me. I've got my timer set, so I hope very much that I will keep to time and let me know how it's going. So as my recent tenure as the president of the Vascular and Endovascular Research Network, and together with my colleague Sandeep Nandrap at Newcastle, we've been leading an international effort really to get experience of all kind of vascular intervention and vascular referrals over and during the COVID-19 period. So not specifically patients with COVID-19, but that whole broad spectrum of patients who participate. So we've seen each other's talks to keep everything quite varied, and I hope that this just presents a snapshot and potentially entering a bit of debate. I'll explain what maybe my impressions are just as a senior registrar rather than a consultant of being on call. And thank you for the introduction. So a brief introduction to the rest of the team, because the work that I'm going to be presenting has been very much a group effort of trainees and early years consultants around the UK, and also everybody who's contributed their data globally, for which we say thank you. Got to say that the funding for the study has come from the VSGBI and from the Circulation Foundation, and with also support with a whole host of organisations around the UK and globally, and from colleagues in Australia, New Zealand, Singapore, etc. So the data that we're looking at, about or just over 1,000 patients who were treated for vascular conditions with surgery or endovascular interventions during the 3-month snapshot periods, mostly in countries who were bang in the middle of their COVID pandemic. Full disclosure, a lot of that data, nearly 50%, but not quite, came from the UK, and then data from around the globe. Actually, it's fantastic. So this is a data with a UK slant, but a global flavour. And that includes the kind of ethnicity. So when it came to acute limb ischemia, we've got some good data for 124 patients, and this is some of the first looks specifically at it. A strong Caucasian slant, again reflecting disclosure when it comes to looking at the data. What has been the experience from people submitting data of acute limb ischemia that they've seen? The comorbidities really are as expected. What is interesting, and what we've noticed in a lot of the work that we've done, is that the actual proportion of patients with confirmed or suspected COVID-19, and because this is data from last year when it all kicked off, and we weren't routinely testing patients, so we couldn't confirm if they had COVID-19, it was actually pretty low. We looked at how unwell these patients were, and you can see perhaps there were proportions of patients who were ASA 1 or 2, majority ASA 3 or 4, very few ASA 5. Part of that reflects the kind of consent that you needed for this study. When we looked at frailty score, a lot of our patients, perhaps as expected, were very frail. We used the frailty score just perhaps as a clue that most of the patients that we were seeing were standard vascular patients. They weren't unexpected or unexpectedly young patients presenting with acute limb ischemia, so not necessarily out of the ordinary. Looking at age at surgery, mean age was 67, a fairly broad range, mid-40s to very elderly patients, a couple of outliers down in the younger age groups, but a bit controversial here, but looking at the distribution by gender, all of the very young patients with the acute limb ischemia were male. Some of this does include trauma. So, I do wonder if a couple of these were some young guys on their motorbikes. Looking at Rutherford, most of the patients were 2, and that's looking at the literature, that's fairly standard. So you did have actually 15% of patients who did have acute ischemia, but actually with a fully viable leg. And it does make you wonder if there are a proportion of patients who were developing occlusions who didn't present to us because of the COVID pandemic. We've seen a drop in many presentations because of that. Most people seem to be treating them with embolectomies or bypass, but mainly embolectomies. Under a quarter treating with mainly endovascular interventions. I think we'll be asking a question about that later on. Very few treating with a hybrid, and whether that reflects the resources available, a drop in the resources, hybrid resources available during the pandemic or not, we can't be sure. And I guess as expected, most of them were urgent. I guess more interestingly, when we dug down into whether or not what people were doing was a change from their normal practice, these are the sorts of things that they said. And actually very few did deviate from their normal practice, perhaps reflecting the acute nature of it, the fact that maybe as vascular surgeons, we're protected by the majority urgent nature and emergency nature of our clinical practice. But most of it relates to delays, and delays specifically because patients were thought to have COVID and they were reluctant to go into theatre, or they couldn't get into theatre because of staffing issues because of COVID. Again, would have done earlier, but they thought patients might have had COVID, and at the time we weren't sure how they would respond. There was one particular patient who has been described as presenting with a stent occlusion because they didn't make their surveillance because of the elective work shutdown. Treatment changes specifically tended towards moving towards more conservative management, using a DOAC instead of warfarin because there was no access to warfarin clinics, or people just couldn't get to and from. Public transport had shut down. One avoidable death, and also, as we said, COVID limiting rapid access to theatre. It will be interesting to see if this is similar globally, the impact of practice. Anaesthetic type, not as much deviation as I would have imagined. As you might expect, some, or at least one patient, a GA was avoided to because of COVID suspicion. Looking at the global surge data, I think that's certainly very reasonable. Relating to their critical condition, because patients were intubated on intensive care, maybe only one. A few had some other issues before their anaesthetic, like a recent heart attack. So the in-hospital complications. The most common complication after revascularization for their acute limb ischemia was either an unplanned return to theatre, and most likely related to ischemia. So what it turns out people were seeing is repeat ischemia after their initial intervention. Whether or not that is more than the re-ischemia and re-thrombosis that it might have seen beforehand, we can't be sure. Cardiac and respiratory were the next most common, but then all of our patients have heavy cardiac and respiratory compromise preoperatively associated with their comorbidities. And then some with bleeding, some with surgical site infection. And this is the paper that we've published looking at the first wave in the Annals of Surgery. And when we look down at the breakdown of in-hospital mortality by indication for acute limb ischemia, the in-hospital mortality, especially during that first wave in the first half of the year, is sitting around 20%. That is significantly larger than reported literature. And again, with a very small proportion of those patients actually being infected with COVID or suspected as having COVID. We think that suggests that there are other causes of this mortality and the complications aside related to systematic changes in practice because of the COVID. I do this comparing it to other published literature. For example, this fantastic US paper which looked at outcomes, but just for bypass of acute limb ischemia. And at 1 year, their mortality was sitting at about 20%. And it wasn't front loaded, it was gradual decline. Whereas looking at our patients, we've got an equivalent mortality, but as an inpatient stay. So our mortality during the COVID pandemic has been very much front loaded. 20% of major amputations, another 18% of rate of graft occlusion, again, all at 1 year. We did manage to ask a question about IV heparin. I find this particularly interesting because there's been so much talk about what people would do and if there were suspicions about prothrombotic conditions. The majority of people did not discharge their patients on any low molecular weight heparin on top of their normal practice. I probably was a little bit surprised about that, but that's absolutely what's been said. Of those people who do discharge their patients, who gave us the kind of the dose, demonstrated the dose, most of them are to put them on treatment dose. Again, whether or not that's their usual practice, I don't know. And then at the bottom, we've got the length of stay that surgeons have been putting their patients on for heparin after their intervention. Huge variety. We have some preliminary 6-month data following our recent data lock for people who've entered their patients into the cover database. And so if you haven't yet put your 6-month or 1-year data in, please do it imminently so that we can include it in the analysis and any subsequent publications. And to throw a spanner in the works, interestingly, the rate or incidence of documented VTE after discharge, almost 0. Returns to theatre, very low. Major amputation at this stage at 6 months, very low, absent. A COVID pneumonia, an additional death, that's the same patient, very low. So our mortality for those patients during the COVID period from this data seems to be, as we said, front-loaded. I've included one case of interest. There are lots more cases during the other talks. I guess to reflect some of our horse and zebra things I thought was a bit interesting, but we had a 54-year-old man presenting to us back in October. I present him because he was quite young. We tend not to see acute limb ischemia in this sort of age group. Sorry. No other background of standard comorbidities, but he did have long-standing back pain and he had long-standing depression. This is slightly relevant because mobility was very limited. So he'd never really had the opportunity recently to see if he'd become a claudicant or not. But after 2 days with a cold, painful leg, a left leg, he came into us and this was his CT scan. So this was the immediate infrarenal segment. His thoracic aorta was clear. His infrarenal segment, thankfully, was clear, but he had thrombus in the infrarenal aorta and around the bifurcation. Occlusion on the right, which was asymptomatic, and this big tug going down into the left. And then moving further down into the limb, he had a patent profunda, but with an occlusion about 5.5 centimeters down into the thigh. Nice patent SFA, but after about 18 centimeters, you can see on the CT scan a really abrupt loss of contrast, and he refilled via collaterals into the very distal popliteal artery. Virtually no perineal at this stage. Couldn't trace the posterior tibial and we couldn't trace the anterior tibial. No contrast going into the foot, but no other findings. So no other intra-abdominal findings related to the solid organs. Immediate management, well, we took him straight to theatre. He had an inflow embolectomy from the groin. We retrieved some clot from the profunda as well, some from the SFA, but we couldn't pass the catheter further down. At that stage, we closed up the common femoral and he had a nice pink foot. We had an emergency case that had also come in, and whether or not that influenced our management and whether or not we would have gone below the knee, I can't be sure, but he had a pink foot. It was in the middle of COVID. He'd had one negative swab, but we couldn't believe that this guy hadn't presented with COVID and this wasn't something to do with that. So we wanted a short, sharp procedure. He'd had to have it under a general anaesthetic. He'd been on intravenous heparin before surgery. He went straight back onto intravenous heparin in recovery, in theatre recovery as well. And for 2 days, he had a nice pink foot. It was warm and he was moving it and it was very comfortable. And he'd stayed on intravenous heparin this entire time because, again, with COVID going around, we didn't know what the optimal treatment for it was. But 2 days later, his pain returned, still on intravenous heparin. We repeated his duplex and he appeared to have thrombosed everything. So suddenly in the lower limb, we had a picture that was worse than before, although at least the inflow was acceptable. So back to theatre he went. At the time, we thought he had some AT that we could get onto, but he had an emergency FEM to AT bypass using reversed vein and fasciotomies. He made a good recovery, and prior to discharge, about a week later, his graft was patent. This was his scan. He went home on dual antiplatelets. Again, we didn't have any positive COVID tests. We had no other reason for what was going on here, but his bypass was working nicely and he was all right. And then on the 25th of January, he came back into us and the acute limb ischemia had returned. Duplex showed that he had occluding thrombus from the origin throughout the graft with no flow seen. And this time the ATA runoff had been lost. The CTA scan confirmed that. When we were looking for runoff, we had a perineal vessel going down to the ankle. We managed to get him into thrombolysis immediately. That was our first choice, again, not for another general anaesthetic. We couldn't be sure why it had gone down, and his runoff vessel had occluded. We managed to get the graft open with thrombolysis, but the runoff was still not very good. We did manage to get the perineal with the eye of faith with the image on the right. You can see that perineal coming down to the ankle with the collaterals crossing over, so that we did have a plantar arch. So he went back to theatre. There was a jump graft from the BK segment of a running graft down onto the perineal, which was back bleeding and it was flushable. So we thought we had a chance. 5 days later, the graft had occluded on duplex. So at that stage, we had nothing else. We had nothing else left. But the foot was warm. He had capillary refill in his toes. So we thought we would give this guy a try with pain management and physiotherapy to see maybe not a leg to run a marathon with, but because he had such limited mobility, we thought it was worth the chance. And obviously we had, I think, 7 negative COVID swabs on this guy. So we also did a full clotting thrombophilia screen, and that actually came back as positive. Do we do this routinely in patients at 50 with the kind of things that he saw? I don't know if it's as routine as maybe it should be. Meanwhile, the rheumatology impression, we had everybody, we're in a tertiary centre, so got everybody involved. They did comment it might have just been raised in the acute period, but he has an interim diagnosis with a plan for repeat antibodies. I'm frustrated to say that we have done that test, but it's still on the system awaited. I would have loved to bring that to the meeting. And obviously, with recommended anticoagulation until his results are known, which for us is a DOAC and an antiplatelet at the moment. So, forefoot ischemia, that forefoot became ischemic. He ended up having a transmetatarsal amputation, and he's made a very slow recovery. Very slow, as you can see. A month later, a breakdown of the transmetatarsal wound, and he now has a below knee amputation, which has healed very well, and actually his mobility is significantly better. Again, long-term DOAC and aspirin, pending his repeat tests. So a slightly long case, I'm sorry, but a bit about this horse and zebra, just to maybe throw a bit of a debate into the works, because actually a historical review I appreciate, but from my previous place of work down in St. George's, looking at the risk of thrombophilia in vascular patients. And actually in the older age group, this guy's a bit younger, but still what we'd expect, it can be up to 20% of our patients if you actually look for it. And in treated acute limb ischemias, so not those that don't present until late, but in treated acute ischemias, in the under 50 age group, we're looking at between 15 to 30% who might have an undiagnosed thrombophilia. So is it possible that we've got an increased distribution, relatively speaking, of acute limb ischemia because we're seeing far fewer carotids, aortic aneurysms, etc.? Are we putting it down to COVID when actually we might be under investigating something else? Thank you very much.
Thank you very much, Ruth, for your talk. And just a reminder to the audience, and for the ones that have sent in questions, thank you for your questions. So we're not going to be able to take your raised hands. You'll have to type in your questions, and the faculty will try and either type in the answers, or Rob and myself will choose some of the questions to be answered live. And also, secondly, at 3 o'clock, we're going to have a minute's silence in respect of Prince Philip, Duke of Edinburgh, and join the rest of the nation. So, so Ruth, before we sort of go on to sort of doing Q&A for your talk, I'm going to launch the next poll for the audience. So I'm just going to do the next poll now, which will be, no, Jeanette, so stop share results. So the question is, what is your preferred strategy for revascularization for the treatment of ALI in patients with COVID-19? So unsurprisingly, a lot of open surgery first. Right. So, so a lot of you said your approach varies from patient to patient, and also quite a large number approached it open surgery first, and then perhaps endovascular, including lysis, which is interesting. So I'm going to ask you, Ruth, what was the approach in your units when all this happened last year?
In terms of treating patients,
Yeah.
approach very much on a patient-by-patient basis. And to be fair, I was on a different unit when it all kicked off first thing last year, but because it was such different scenarios, we had a lot of intensive care patients, for example, who were very poor. So if you could, most of the time you were removing the art line. That was probably our first strategy. Yeah. And then intravenous heparin where possible. Those acute patients presenting otherwise, yeah, open surgery for sure.
So there's a question from Laura Drudy saying, what frailty score did you use in the Verne study or your study? Is it just a frailty index which reflects a just comorbid state, or is it a frailty score that reflects global vulnerability?
It's a clinical frailty index. So I guess I'm not entirely sure what you mean, because it's nothing to do, the frailty index is nothing to do with a comorbid state, the one that we used. So I suppose what you mean is, yes, it reflects global vulnerability. So it looks at whether or not you're completely independent, whether or not you help, whether you need help with certain things, that sort.
Yeah. So also as a sort of question about heparinization, and I think sort of post-interventional pharmacotherapy. I mean, in our unit, we used a lot of sort of treatment dose, low molecular weight heparin, following interventions, you know, full dose plus heparin for 6 weeks. It's very interesting to see from your data that actually very few people adopted that strategy. And, you know, any comments on that? What would you recommend following intervention in these patients?
I guess the practice where I was working hadn't changed, and we didn't see significant numbers of representations. So I would say you go with, in the absence of evidence, we have to accept there is an absence of evidence. You've got to go with what you think is safe and what you think is reproducible. So I wouldn't have changed my practice based on that. Yeah. I'd just carry on going with the guideline-based evidence.
Yeah, I noticed the patient was discharged with dual antiplatelet therapy and then re-occluded. So, yeah. With
potentially thrombophilia, whole zebra.
Yes. Someone asked, Mohammed Chima asked, is there any therapeutic advantage for IV heparin compared to therapeutic enoxaparin in ALI, other than short life, half-life in view of possible reintervention?
There is some minor evidence that intravenous heparin potentially has a slightly lytic action compared to treatment dose clexane, which we looked up before. Again, the evidence is mild. It comes with plenty of disadvantages if it can't be managed properly. So it's certainly got its disadvantages, but yeah, slight evidence of lytic effect, I think.
Can I ask the faculty as well, anyone's got any strong views on that, you know, full treatment dose of low molecular weight heparin or intravenous unfractionated heparin for ALI? Yeah, Robbie.
Yeah, so out here, I mean, certainly my preference is low molecular weight heparin, and that's partially because where we work, monitoring the heparin accurately is difficult. In this part of the world, quality control regarding the heparin can be a challenge. While with low molecular weight heparin, we're kind of certain that what we're giving is getting given. And in general, my preference has been to use dalteparin because it has a slightly shorter half-life than enoxaparin as my first line if I'm going to use an anticoagulant. And just to make a comment on Ruth's talk with that young patient, we've also had the same kind of experience that generally young people coming with acute thrombotic events, there's some hidden thrombophilia somewhere which we need to look for. We are not as aggressive on it as we maybe should be. But yeah, I would certainly look at that.
Sure. Okay, I think it's time to go on to our next speaker. Robbie, over to you.
Thank you very much. So I will just get my slides up and running. So the slides are visible, yeah? Yeah, okay. So I'm going to be talking about what our experience has been in the Indian subcontinent, and going to kind of run through this in terms of how the COVID pandemic has evolved in India over the last few months. So this is data from today. So we currently have a huge number of COVID positive patients across the country. We are a population of 1.2 billion. So those numbers are big by themselves, but we are in the middle of a huge second wave to the extent that hospitals are running out of oxygen, they're running out of beds, they're running out of ventilators, we're running out of medicines. So it is a disaster that is evolving as we go on. The current figures, there's a sudden spike that we are seeing far beyond what we had seen in the first wave. And where I work is down in the south, down here. So we are not yet at the peak of where other parts of India have been, but we can see the impact of COVID. And the difference this time has been that unlike in the previous first wave when people were very careful and hospitals were empty and people won't come into hospital, this time things are different. The streets are crowded, the markets are crowded, everybody's out. And they don't seem to think COVID is there, but it's spreading and we're seeing the consequences of that. So let me go back to when we began to have our first cases of COVID. So on the 23rd of March, India went into the world's largest lockdown. They literally shut down the whole country. It was like there's a curfew across, you can't get out on the streets. To get on the streets to go to hospital, you had to carry a special police pass and all of that. So in April 2020, a 64-year-old presents with left leg pain and discoloration, SVS2B. He's been needing oxygen supplementation and was commenced on low molecular weight heparin while awaiting COVID confirmation. Now, today things would be different, but at that time, COVID was almost thought of as Ebola. You know, it's extremely infective, extremely dangerous. We had to isolate patients. We had to wait to confirm whether they were COVID positive or negative before you did anything. You could not get them into a theater before that. So there was an 18-hour delay before we got a COVID confirmation that he was indeed positive. And that's his CT scan from the day. And as you can look right there in the middle of the descending of the infrarenal aorta, big chunk of clot on the medial wall, hanging down like a tongue into the left common iliac, and the right side looks clean. And what he had was clean vessels on the right side, no calcification, nothing else over there. And his distal runoff had been pretty much trashed out, pretty much from below the mid-calf. Again, COVID times. So this was the first COVID positive surgical case in our hospital. So it was a big deal. You know, nobody quite knew what to do, where the patients get shifted, dedicate a lift to move patients around. But anyway, we get into theater. We decided let's make it a 2-consultant operation so that it's a quick in, quick out. Full PPE, which involved wearing the whole kit, your visors, your glasses. And you realize the difficulty of operating at that time when you're not comfortable with your glasses fogging up, water dripping down them, you can't see very well through your loops. So anyway, the decision was we're going to do a bilateral transfemoral embolectomy with the left below-knee amputation, which was partially because the leg was very borderline and we were already past the time when we could have been able to do anything. So he got that, went off home. And we realized what the challenge is. PPE is a problem. Your loops fog up. You need to be well prepared, have all your equipment in theater. You can't keep asking for something new in the middle of this. There's a lot of fear of the unknown as to what's going to happen with these patients, what's going to happen with you. And at that stage, there was literature out there saying that 40% of COVID positive patients who have an emergency surgery will die. And you know, that's at the back of your mind when you're trying to take a decision as to what to do. So that was April 2020, our first COVID positive case. We had a fair share of stuff going on in the middle. Then comes August 2020, 53-year-old lady with vertigo for 3 days and a cold, numb left upper limb for the past 4 days, a history of fever for the past 10 days. And during the course of this evaluation happening outside, she's also got a new diagnosis of diabetes with an HbA1c of 14, which corresponds to significantly high sugar, significantly uncontrolled diabetes. And that's what her hand looked like. It's purple, it's dusky, it's cold. There's some early mottling over there. And CT scan done at the time shows two things. So she's got this clot that is hanging in her, sorry, apologies. So she has this clot in her proximal subclavian artery, big chunk completely occluding it. And she had also embolized distally into her arm. And the rest of the aorta looks clean, no other clot elsewhere. So older lady by Indian standards with a new diagnosis of diabetes and other comorbidity. So she underwent a brachial and a radial and an ulnar embolectomy. And on table, what we tended to do is that into the distal vasculature, we instill some urokinase or actylize into that to try and open up whatever is possible distally. And we weren't happy with the proximal inflow, and we do this in a hybrid theater. So she also got a subclavian stent and did fine, went home. September 2020, another gentleman comes in who's been admitted to the hospital on oxygen with COVID, confirmed. He's on steroids, on remdesivir and low molecular weight heparin prophylaxis, getting 40 of enoxaparin once a day. Develops abdominal pain on day 5 of admission to hospital. So this is not acute limb ischemia, but this is again acute ischemia, which we get to see as vascular surgeons. So if you look at that, kidney looks fine. There comes his aorta, and there's this abrupt cutoff in his superior mesenteric artery. So the proximal superior mesenteric is open, the gastroduodenal is open, the celiac is open, but beyond that, nothing else. And at that stage, the gut did not show any obvious signs of ischemia, air in the mesenteric wall, nothing of that sort. So what we decided was, let us take him off a catheter-directed thrombolysis. So we got a catheter and went in fairly straightforward. As you can see, there's a flush occlusion there. The wire passed through this thrombus fairly easily. As expected, this was a soft clot. So we got in a Craig-McNamara catheter and set him up for thrombolysis. But interesting, you can see this faint flow of contrast. The outflow is really poor. So this thrombus has really taken out a lot of the distal outflow as well. He gets 24 hours of catheter-directed thrombolysis. Next day, they take him off for a diagnostic laparoscopy, followed by resection of 240 centimeters of the small bowel, but eventually goes on to get this bowel joined up back again. So 2.5 months later, stomas have been closed, and he is fine with a bit of short bowel syndrome features, but not too bad, managing. 2nd December 2020, a 62-year-old hypertensive diabetic, COVID positive, needing in-hospital care for a week. And he was discharged 2 weeks prior to reappearing to us. And he had been discharged on a prophylactic NOAC. So that had been part of the change that had happened in the hospital as COVID went on, that we were discharging everybody on NOACs for at least 4 weeks. The thought process being thromboembolic events can be disastrous. The risks of bleeding with anticoagulation is probably not that high. So he'd finished that, he'd finished his NOACs, and he comes to us with forfeit discoloration and toe gangrene. So pretty much from ankle downwards, the foot is cold and pale, and he's only got a femoral pulse palpable in the index limb. At admission, he's quite toxic, he's acidotic, he was confused, his creatinine was up, and he had evolving sepsis from where these toes were gangrenous. So he'd been sitting on this for a bit before he came to us. Managed to get a CT scan done because that's what we needed to do. And CT there, if you look at it, The iliacs were clear. You can see the clot hanging in the profunda femoris, which then completely occludes. You can see the circumferential calcification in the profunda femoris as you come on down. Lots of calcium, well, significant amounts of calcium in both these SFAs. So this certainly is chronic limb ischemia that exists. And then when you come further down, clot from the P2, P3 segment, and then below that, it's essentially just all clot, bits of calcium, no significant visualized runoff, except for what looks like a posterior tibial artery, which comes and dies before it crosses the ankle. So what we do, we decided to take him for a transfemoral embolectomy with a vein patch going down onto the second division of the profunda, opened up his popliteals and cleared them, opened up his anterior tibial and posterior tibial at the ankle, cleared them, not getting great flows. So we did on-table angioplasties of the anterior and posterior tibial retrograde, debrided the foot at the end of establishing the reperfusion. And he goes back to the ITU. 2 days later, while on the ITU, he has a seizure episode. So when you do an MRI, we see he has got posterior circulation infarcts, which have undergone a hemorrhagic transformation while has been on all the anticoagulation, low molecular weight heparin, antiplatelets, everything. So we have to stop his anticoagulation and his antiplatelets. Eventually goes home 6 days later on just aspirin at that stage. 1 a.m. on 20th December, he comes with a massive bleed from the groin wound. The leg is well perfused. We take him to theater in the middle of the night, open up the groin, the patch has given way at a point, we wash it all out, there's no pus at that point, wash it all out as thoroughly as we can, sartorius flap, start off an irrigation whack over that, put him onto broad spectrum antibiotics. 2 a.m. on 26th December, and believe me, this is the week I had taken off from work. I spent most of the time back in hospital. Another massive bleed from the groin and while in the ICU. We rush him back to theater with the resident holding his groin and opening him up. And this time we ligated his external iliac, common femoral, superficial femoral, and profunda femoris, and did a high above knee amputation. Left the flaps open. 4 a.m. on the 4th of Jan, he bled again from some branches of the profunda getting flow from the internal iliac. Explored again, ligated that again. Then he gets a massive infection in the stump. There is pus pouring out of it. The whole thing falls apart. The skin gets chewed up where a sartorius flap is. And over the period of 5th Jan to 23rd March, we go to theater, I think about 35 times, get this all cleaned up until about 2 weeks ago when we trimmed the bone back and we've got a mound of flesh over there. So what is left of the stump is healing, but the patient's not in that great shape after having gone through all this. This is from yesterday. 68-year-old diagnosed with COVID 2 weeks ago, was mildly unwell with it. Develops acute left upper limb ischemia 24 hours ago. He's got a clot sitting in from the mid-brachial going with runoff just appearing at the wrist. So we've done so this is his CT scan. We did the embolectomy for him. And as you look at this CT here, he has this big chunk of clot in his descending thoracic aorta. And this is literally opposite the origin of the left subclavian artery. The proximal left subclavian itself is clear and everything beyond that is clear as well. So this is similar to an entity which is seen even in non-COVID times, something that is referred to as primary aortic mural thrombus. We had a paper on this many years ago where we had classified it into these 4 types. And so this gentleman fits into what's called a type 2A aortic mural thrombus. And these are ones that we would treat, especially if it's a large clot, with a stent or a stent graft to trap it. You can anticoagulate also, but there is risk with the anticoagulation, so he is planned for that. So looking at what we've been through, some of the lessons we learned, one is that I felt it's not actually that common in our experience. So we haven't seen as many COVID ALIs as we would have been seeing earlier. Now, perhaps it's because patients haven't been coming to theater, they've been getting treated locally. PP makes life tough, especially if you have to do fine work. So either you get used to it or you've got to compromise on what you do, because doing fine work wearing PP for a long time is really difficult. beware of other sites of thromboembolism. We got our fingers burnt with this. So brain strokes happen even while they have an acute upper limb ischemia. Use everything that's available. Endovascular is attractive because it's relatively more comfortable to work with and you can get good results with imaging. Keep it short and simple is what I thought works, but it's hard to do always. So the question I always have is it COVID ALI versus acute limb ischemia with COVID, or is it acute limb ischemia post-COVID? So I think this is part of the question that all of us have to answer for ourselves. One thing we found was most of the patients coming with ALI, lots of them also had other comorbidities which would contribute to developing limb ischemia. So it's not just purely COVID, but there's other stuff also in addition. Thank you.
Thank you, Robbie. That was an excellent presentation. I think you've gone through the full armamentarium of the vascular surgeon there in one talk altogether. Do you think that there's an element of people being reluctant to come to hospital at the initial symptoms that has contributed to the severity, if you like, of the presentation you're seeing in your unit?
That is a very valid point, Rob. We've certainly heard this across the board, across India. So in India, there's actually a very few number of vascular surgeons for the size of our population. So lots of us are seeing patients presenting to us late with advanced limb ischemia, and especially in the early phase, the amputation rates has certainly gone up. I think primarily because patients are presenting late, and maybe there's a bit of surgical nihilism as well as to what's possible and what can be done. So yes, definitely.
Okay. So we've got a question from Eric Lim, and just as we're going into the questions, I've launched the third poll if people can address that as we go along, just so we stick to time. So Eric Lim has asked, any reason why the patient with the clot in the SMA did not proceed directly to theatre for a laparotomy and SMA embolectomy in the first place? I guess the question is, how do you tackle SMA thrombus or emboli to begin with, and has that changed during COVID?
Yeah, so ordinarily a patient like that would go straight into theatre for an SMA embolectomy. But I think having an active COVID diagnosis, our experience of having the difficulty of doing fine microvascular work while wearing all your PPE, and the fact that patients with acute mesenteric ischemia tend to do so badly anyway, even at the best of times, and the combination with everything else probably swung our decision to try catheter-directed thrombolysis. And to be fair, there's reasonable evidence that shows it works quite well for some patients. So I don't think it was unreasonable to do that.
Yeah, I tend to agree to be, but do you think there's a bit of reticence from surgeons in general to begin with, when we were not quite so sure what the diagnosis of COVID meant, not just for the patient, but for the staff and ourselves, in fact, and how the PP might be protecting us?
Absolutely agree with that, Rob. I think we've all been, so I think when COVID first appeared on the horizon, it was almost equated to like Ebola or, the Black Plague, and you don't know how bad it's going to be. And then comes the data that 40% of your patients will die if you operate on them, which makes you think, I really need to have a really good reason to be taking them to theatre to perform a life-saving intervention. Certainly as time has evolved, we've realized that it's not quite so bad, neither the disease nor the prognosis if you operate on them. So I think we've become a little more confident that we can surgically deliver better results than I felt we could have done at that time.
So we've got a question here from Badri Vijayanagar, which is very timely actually, given what we're seeing in the UK. What is the experience of thrombosis or vaccine-induced thrombosis with the COVID vaccines in India currently?
So, excellent question, and very, very timely, as you said. So about 3 hours ago, we finished thrombolysis on a guy who had an extensive iliofemoral unprovoked DVT, who received the Covishield, which is the AstraZeneca vaccine, 2 weeks ago. He has no risk factors that we can find that have triggered this. We are sending off an APLA workup, which we do in younger people, in people like this. But yeah, so this is the first one we have seen a DVT 2 weeks post-vaccination. So is it induced, not induced? We don't know yet. But to be fair, this gentleman did have a May-Thurner syndrome. So he has a tight common iliac. So he has an underlying anatomic reason which predisposes him. You had to stent that. Did the COVID vaccine tip him over and cause him to get a clot. Don't know.
Yeah, I guess that's the question. Does COVID act as that second hit you classically see in these venous thrombotic episodes? Got another question here from Eric. The second case patient which you described with the upper limb ischemia, you mentioned giving Actilyze intraoperatively. Do you commonly do this in your unit for patients with upper limb embolectomies?
We do. So I think maybe we see patients a bit later because of the geographies and the kind of challenges for patients to come to healthcare and get operated. So we do tend to do an embolectomy. And then into the distal circulation, we will put in about 5 to 10 milligrams of Actilyze, or approximately 2 lakh units of urokinase. Leave the distal vessel clamp for about 10 minutes. And only at the end of that, restore proximal flow and close up. And this is something that I learned in my time in the UK from one of my bosses in Belfast. So I'd done a brachial embolectomy for a lady, and her thumb would not pink up. He just told me stick a bit of Actilyze down there, and when we reperfused her, half an hour later she was good. So yeah, it's something we do use. Okay.
So I've just shared the results from the third poll. The third poll was the question is, in patients with COVID-19 after an ALI event and intervention, what is the best post-discharge pharmacotherapy? I suspect we don't know the answer to that as a group, but I guess that the question is, what do individuals utilize themselves? And there seems to be an overwhelming preference for oral anticoagulation with a single antiplatelet therapy. Can I just get the views of the panelists, or what they like to utilize, and perhaps more pertinently, why they've chosen that over any of the other options? So starting with yourself, Robbie.
Oral anticoagulant and aspirin.
That's what you use as standard?
Sorry?
Is that what you would use as standard, or has COVID influenced your choice?
Standard. So anybody with a thrombotic or an embolic episode, oral anticoagulant with aspirin.
Okay. Max, any different to that, or?
I do that. I send them home on a couple weeks of low molecular weight heparin and an antiplatelet, and then convert them to one of the novel oral anticoagulants when they follow up in clinic. And that's my approach for acute limb ischemia in general.
Okay. Christian?
I think oral anticoagulant only, no antiplatelet in addition.
And has that changed during COVID? Is that your standard protocol?
No, that's standard protocol, and as far as I know, I would do that to all peripheral vascular patients. If they need an oral anticoagulation, then there's no need for an additional antiplatelet for me.
Ruth and Patrick, anything that we do differently around the regions in this country? Ruth?
So we're not licensed to use a DOAC from our primary care trust. I don't know if you guys have experience of that around the UK. So oral anticoagulant, yes, but warfarin rather than a DOAC, which personally would be, if I was a patient, would be my choice. But yeah, warfarin.
Patrick?
So we've sort of been pragmatic. We use a little bit like Max, 6 weeks, not 2 weeks, of low molecular weight heparin and aspirin. And then we convert to River and aspirin at 6 weeks when we see them in the clinic, and they're fine.
I mean, we utilize our standard protocol, which is an oral anticoagulant. And we have sort of moved across to the DOACs from warfarin. But to be fair, we still do send a fair portion home on warfarin as a preference, particularly some of our more senior colleagues. And we've had some people come back, shall we say, who've had further thrombotic events who've been on DOACs alone. And perhaps adding in the antiplatelet therapy does offer a degree of protection against that in itself as well. So it's good to see that.
Sorry, Rob, the problem with low molecular weight heparin and warfarin, they need to come back for blood tests. And during COVID-19, that was not desirable.
Yeah, just about to mention that. That's been the true. It's the ability to get access to the primary care facilities, isn't it, during COVID, particularly to the early part of COVID, which proved problematic to us. So just drawing this to a conclusion, we seem to have timed it perfectly for Patrick to introduce the minute silence. So across to you, Patrick.
You're muted.
Fantastic. Okay, so that's the minute silence for His Royal Highness the Prince Philip, who's unfortunately passed away earlier this week in the UK. Moving on to a positive note, I'm delighted to introduce Max Waller, who's going to provide us with an American flavour of the discussion. Across to yourself, Max.
Thanks. Can you see my screen? I'd like to start with introducing the horseshoe crab, and thanks for the opportunity to present. The horseshoe crab is an ancient organism that gives a glimpse into the convergence of the coagulation and inflammatory systems. They evolved through a common ancestor early in eukaryotic development, and these systems continue to function as a highly integrated unit. In fact, an animal model for antiphospholipid antibody syndrome is injecting a mouse with the CMV virus. And we're seeing in COVID-19 antiphospholipid antibodies that are circulating. Coagulation defects have been described with other respiratory viruses as well. And endothelial dysfunction, inflammation, cytokine release, hypercoagulability, and hypoxia contribute to thrombosis. And here's an example of the endothelial dysfunction. Increased secretion of cytokines and complement-mediated microvascular injury all play a role. This is a review from the Lombardy region of Italy, which was one of the first published, where they saw a 5-fold increase in acute limb ischemia during the COVID surge. And they noted surgical revascularization was associated with a high technical failure rate in this cohort, which may be due to an inherent virus-related underlying hypercoagulable state. And in their series, they describe a characteristic pink and tan clot, as you can see on the right side. And they also demonstrate no reflow phenomenon into the foot. It's a very tenacious clot and a very tenacious syndrome to treat, as we are all experiencing. The incidence of ALI in patients with COVID-19 who require hospitalization ranges from 3 to 15%. And it's distributed predominantly in the lower extremity, but it can be in other anatomic beds. In contrast, the incidence of ALI in the general population is about 10 to 15 per 100,000 per year. And the Rutherford Classification describes the immediate threat. And it's important to have a standard definition, a convention for acute limb ischemia. And so for our research projects, we're using the Voyager PAD trial convention. ALI can affect patients with severe COVID-19. It can also occur in about 20% of patients who present with COVID-19 with relatively few symptoms or even asymptomatic. So sometimes we rely on other clues like elevated D-dimer. So ALI can occur with ALI risk factors like PAD, cigarette smoking, obesity, diabetes. It can also occur without these risk factors, and it can occur despite chemoprophylaxis, which makes the treatment very challenging. The mortality rate of COVID-19 for those who require hospitalization is over 20%. COVID-19 patients who develop ALI have a mortality up to 50%. And there's a variety of approaches to intervention: medical management, an endovascular approach, a surgical approach, a hybrid approach. Silingardi et al. Described aortic floating thrombus, and like what Robbie mentioned, the primary aortic mural thrombus. And in this case, after 8 days of anticoagulation and antiplatelet therapy, the thrombus resolved without surgery. I'm going to present a handful of cases to illustrate what we're talking about. This is an otherwise healthy retired football player who presents to the ED 2 weeks after a positive COVID test. And he had a D-dimer that was elevated, although we've seen D-dimers in the hundreds of thousands range. And he presented and kind of decompensated to Rutherford 2B ALI. And this is what his foot looked like on the morning of intervention. I chose a percutaneous approach to avoid general anesthesia, and the DSA shows a popliteal occlusion and absent runoff. I performed catheter-directed aspiration thrombectomy using a penumbra Cat 8 in the above knee popliteal artery, a Cat 6 in the below knee popliteal artery, and a Cat 3 to get the thrombus from the distal PT. And at the end of the case, he had a palpable PT pulse. And this is what his foot looked like. Clinic follow-up, he has normal ABIs and a normal arterial duplex. Here's another case. This is a patient in her 50s who presented with tibial occlusion, initially treated with heparin and improved anticoagulation. She was discharged on an oral anticoagulant. Her initial COVID PCR was negative. However, she returned to the ED with rest pain and toe discoloration, and on repeat, COVID PCR positive. Asymptomatic. DSA shows normal flow up to the below knee popliteal artery, and then she has an abrupt occlusion of her perineal, PT, and AT at about 10 centimeters above the ankle, and really no flow into her foot. After a percutaneous aspiration thrombectomy, intraarterial TPA, and balloon angioplasty of the PO loop, I got her DP open. She required a toe amputation, discharged on a wound vac. And this was a really challenging case. She was extremely hypercoagulable. So I discharged her on low molecular weight heparin, converted her to rivaroxaban. I also had her on cilostazol, a calcium channel blocker, and dual antiplatelet therapy. I mean, I threw everything but the kitchen sink at her. She required a toe amputation, and on follow-up in 3 months, that toe amputation healed, and she had a normal pedal acceleration time, even though her AT and her DP had occluded and she was filling via collaterals. Here's a third case, courtesy of Dr. Nikolai. COVID positive early in the pandemic, proned on a ventilator and had occluded popliteal and tibial arteries. You can see that foot. After 2 days, re-occluded, even though the patient was on therapeutic heparin. Had a repeat embolectomy, transpopliteal and transtibial at the ankle, and also an embolectomy of the arch with the number 2 Fogarty, and had no reflow phenomenon. So initiated iliopros therapy and low molecular weight heparin, and the patient is doing well in recent clinic follow-up and the foot is healed. This is a patient with history of PAD, underwent an embolectomy, but developed recurrent ALI. On return to the OR, surgeons placed an AV fistula from the posterior tibial artery to the tibial vein and was discharged on warfarin. And there's the AV fistula. and that patient recovered. This is a patient with diabetes who is prone on a ventilator. Similar story, palpable DP pulse at the end of the case, discharged with a tracheostomy, was in the ICU for a long time. He recovered. He's seen in follow-up, he's doing well. He lives in the mountains and he's back to hiking in the Dolomites. And I've shown a handful of cases that went well overall. It's really important to remember that in spite of effective treatment strategies, the mortality in critically ill patients with COVID-19 who develop acute limb ischemia remains high. And this is an example of a patient who is critically ill on a ventilator and had aortic floating thrombus in it at the bifurcation, and also presented with a right ICA occlusion and stroke. And unfortunately, this patient ultimately died from the COVID pneumonia despite successful revascularization. There's ongoing research initiatives. There's an international REDCap registry that I'm going to talk about, and a project that I call the CLOT study, which is proteomics of acute limb ischemia. So the international registry evaluates the components of the diagnostic workup, describes surgical endovascular non-operative management, and investigates various perioperative and postoperative anticoagulation strategies. So I'm the co-founder of the Vascular Surgery COVID-19 Collaborative, and we put together, along with Dr. Rob Cuff, and we put together an international working group to design modules to look at the impact of postponing scheduled operations, and also look at the impact of COVID and the thrombotic complications associated with COVID. We developed 4 modules: acute limb ischemia, acute mesenteric ischemia, stroke, and symptomatic VTE. And why is this important? Well, we talked a lot about it already, and it brings me to 2 articles. The first article talks about prescribing patterns of antiplatelet agents. This was presented in 2012. And the authors show that essentially, if you ask 5 vascular surgeons what their antiplatelet discharge strategy is following an intervention, you'll get 6 different answers. It's highly variable. And then the editors of the European Journal of Vascular Endovascular Surgery, Martin Bjork, Jonathan Boyle, and Florian Dick, published a great editorial highlighting the need of research initiatives amidst and after the COVID-19 pandemic. And so to answer a lot of the questions that we're talking about today, the case series and the case reports and the anecdotes are great. And vascular surgeons are the vascular specialists. And together we will provide high quality data to guide management. And that's really what we need to answer a lot of the questions that we're grappling with right now. VASC is partnering with Fondazione Policlinico Universitario Gemelli in Rome. Professor Tonelli and his team are the VASC European Hub. And we're partnering with CPC Clinical Research, Dr. Banaka, Dr. Hyatt, who's deceased. And we'll continue to work with VQI and other national registries to harmonize our COVID-19 variables. I have a minute or 2 left to talk about our proteomics study. This is one of the patients, and this is the characteristic kind of brown and pink and tan clot. In our COVID patient, we see a 6-fold increase in fibrinogen crosslinks compared to a similar patient who does not have COVID, who presented with acute limb ischemia, looking at their clot. We're seeing a variety of different proteins expressed, including an abundance of innate immune response, adaptive immune response, and response to viral proteins. Thank you so much.
Thank you, Rob, for that. Thank you, Max, for that talk. And also, I'd like to answer perhaps a question from the audience just now, and it's gone. And what they wanted to ask you, Max, was whether or not you change your sort of anticoagulation strategies with acute lower limb ischemia patients prior to the coronavirus pandemic and during the coronavirus pandemic in your unit, Max.
Yes, so I did. And like I said, I'm looking forward to completion of the studies and what Ruth has done and everyone's contribution to the field. So we really have some high quality data to guide management. What I did differently, talking to colleagues and asking around, is I used 10A levels for monitoring heparin in the hospital. I have found that using PTTs, they're sometimes falsely elevated if there's a circulating lupus anticoagulant. I think adding an antiplatelet is important for the arterial thrombotic events, and I'm seeing the benefit outweigh the risk, especially in the most challenging cases. Adding even things like cilostazol, adding a calcium channel blocker like I highlighted in my case.
So we use 10A levels in the ITU situation with sort of quite extensive DVT in some patients. But I must admit that with our arterial sort of patients, the vascular unit never really engaged in 10A levels. And I'd be interested to know from the rest of the panel what use of the 10A sort of assay that they use for their arterial patients. Anyone? Rob in Leicester?
We're very much the same as you, Patrick. We can get access to it for the ITU patients, but we certainly don't use it as part of routine for ward-based patients. And to be fair, access for our ward-based patients to the ITU has been very difficult anyway. So on the whole, from a vascular surgical perspective, we haven't been utilizing 10A routinely for our patients.
Yeah, so that's it leads on to what Robbie said about sort of the difficulties of monitoring therapeutic levels of unfractionated heparin. And that's the advice that I got from Tamara Everington, one of our very sort of, expert hematologists here down south. And so, we used a lot more low molecular weight heparin. But I'd like to ask you, Max, about iloprost. Now, that case shared from Italy was a very sort of, interesting case, very aggressive limb salvage. How much iloprost did you end up using in the pandemic? And we found it to be really expensive. And, did it make much of a difference in the outcomes, Max?
I defer to Dr. Nicolai. I think she's on the webinar for the dosing. I've not used it for COVID. I've used prostaglandin infusion, intraarterial infusion for a patient with Crest syndrome, with Sjogren's, and it is challenging to inject. I do it in the OR under general anesthesia to watch for a drop in blood pressure using an A-line. So if Dr. Nicolai is on the webinar, maybe you can post in the chat your strategy, how you what you're dosing and how you administered it.
So we're going to launch the next poll, which factor is the most important priority for planning intervention in ALI and COVID-19? And we're interested in the audience's answers. So Max, which factor do you think is the most important priority for planning intervention in ALI and COVID-19?
Well, I think the take-home points are that this is a really tenacious problem, and you've got to be more tenacious than the clot. And at the same time, you need to know when to say when. So for me, it's avoiding intubation, because I think that can exacerbate and accelerate a patient's demise when they come in with COVID.
Yeah. And I found as well that if you don't get it right first time round, usually the results are pretty poor for patients. they have to go back several times. Sorry, Robbie, you want to say something?
Right. So just to chime in on the iloprost. So in India, we use quite a bit of iloprost for the chronic limb-threatening ischemia, the classic Berger's disease where there is really no outflow. And we do use it to supplement ALIs where there's been extensive thrombosis of the small vessels. And personal experience has been that it works. It bails you out of trouble. The borderline limbs tend to get salvaged. We haven't used iloprost for a COVID patient as far as I can remember. But in non-COVID ALIs, we found it helpful. And there is some literature there, especially for the Berger's associated limb ischemia and iloprost.
So, all right, I think we better move on. Thank you very much, Max, for your talk. We're going to move on to Christian Alexander Behrendt's talk now. Christian, over to you.
Yes, so I hope you can see my slides now.
Yes.
Already working? Can you see them?
Yes.
Perfect. Okay. Hi, everyone. Thank you, Rob and Patrick, for inviting me to this excellent webinar. Impressive presentations. I will try to keep it very brief and not take much of your time. I have no disclosures related to this talk. I really like controversies. I don't like it when it gets so straightforward and there are no question marks. And maybe you have read some of our recent publications where I try to focus on disparities between reimbursement systems and countries. And since this pandemic began in December 2019, for me, one of the most important questions is if this global pandemic has the same impact in all countries. And the truth is, or my suggestion would be that we don't always know the numerators and denominators. So this talk will be slightly influenced by this idea. I don't know if you can remember what you did 1 year ago in February 2020. I was skiing in the Dolomites together with my wife and my son, and I also remember that we sat in the hotel restaurant and everybody was joking because a lot of people were sick and had a fever, and the World Health Organization issued this new word COVID-19, and we all made jokes about, yeah, maybe they have all COVID-19. Then we got back to Hamburg. I started to work again. Patients still presented with the ordinary traumatic vessel injury or once in a while an ordinary carotid embolism. But then in March 2020, even in Germany, extensive restrictions came into force, and everything changed then. And in the first time, everything was unsure, but then the first case reports and case series were published suggesting an association between acute limb ischemia and COVID-19. As far as I know, there's even a systematic review most recently published. This is covering less than 50 or 60 patients. It's just a few publications, and the question mark is still there. Is this coincidence, or is this maybe a publication bias, or is there actually an association or even a causal relation between COVID-19 and acute limb ischemia? I also noted this interesting publication by Belosta and colleagues concerning the hospital admission rates or incidence in a severely affected region in the Lombardy in Italy. They actually made an interesting point. The incidence increased from nearly 2% to more than 16%. However, only 20 SARS-CoV-2 positive patients were included here. You know how that is in the different reimbursement systems and health care systems. There may be a selection because some hospitals closed down and patients were forwarded to other centers. I'm not so sure, but obviously in this severely affected region, there was an effect. There's another multicentric retrospective observational study from the United States, Massachusetts region. They did a similar comparison of 3 different durations when the first World Health Organization issue was published until July, summer 2020, and this included 65 patients with acute limb ischemia. The authors discussed that the validity was still limited. They have not found any statistically significant difference, but a trend towards declining admission rates. And if the patient was admitted for acute limb ischemia, there was an increasingly severe course. That's obviously interesting. I want to present a very brief insight into a German study. This is a post-mortem study from our Department of Legal Medicine in Hamburg. And one of the advantages of this metropolitan area and the system in legal medicine is that all the patients deceased with SARS-CoV-2 positive testings will be transferred to this Department of Legal Medicine. So they have I think examined approximately 250 patients already. And what they found in this published series of 80 positive patients was that up to 20% had a pulmonary embolism. However, only 1% or less actually had any peripheral arterial occlusion. So this is a bit in contrast to what is always discussed in series and case reports, but this is the reality in a consecutive series in a postmortem study. And if you see the risk factors published by the World Health Organization, CDC, and other authorities, and you took all them together, this describes the prototype of a patient with a peripheral arterial occlusive disease, and they are obviously at high risk of an acute limb ischemia, and they have a 4 times higher risk to be hospitalized and for severe illness. So if this is the case, and these are our patients with PAD, where is the collateral damage? A collateral damage can be indirectly modified by staff shortage, delayed processes in the hospital or emergency room department directly through the virus impact, or it can be an effect of data selection bias, confounding, and all that. And the remaining question is this just an anecdote or a real world problem? In 2020, we used large-scale health insurance claims, including more than 100,000 hospitalizations, to determine how the admission rates, the hospital admission rates for the main cardiovascular emergencies developed. And if you look at the acute limb ischemia diagram here, you can see as soon as the extensive restrictions in Germany were applied, the hospital admission rates declined significantly. This was interesting, but yes, you can always say maybe the patients don't present, they die at home or die in the outpatient facility or just lose their leg and nobody says they have an acute limb problem. There is a lot of limitations with the data we use here nowadays, but there is no better data in my opinion. Then in a follow-up study published most recently in the European Journal of Vascular Endovascular Surgery, we used a larger data set, same health insurance fund, more than 300,000 hospitalizations. We confirmed that the hospital incidence declined during the pandemic, but among 2.4 patients with a SARS-CoV-2 positive testing, the hospital mortality increased in patients with acute limb ischemia. So we can say that there is a declining incidence, but maybe an increased disease severity. I brought a clinical case that was very dramatic, so I think it may be interesting to hear this experience. It's a young male patient. Besides obesity and smoking, he was more or less healthy. He experienced chest pain, acute paraplegia, and a blood pressure difference. So this is obviously a no-brainer. He was transferred from another emergency department to our unit, and there were conflicting test results with positive and negative testings. Ultimately, when he presented in our emergency room, we had a positive PCR, elevated white blood cell counts, D-dimers, lactate, and a pathological electrocardiogram. So he went through the CT scan. It was an acute type A aortic dissection, obviously also with an ischemia of both legs, right more than left. But life before limb, he got to the operating room through the night. Our colleagues from cardiac surgery implanted the frozen elephant trunk. And the next day, when he was presented to us with this remaining complete leg ischemia, he had a massive compartment syndrome of the right thigh and lower leg. We immediately took him to the hybrid OR. He received a complete fasciotomy, and we did an angiography. We landed in the true lumen, and as you can see here in the angiography, he had an occlusion of the aortic bifurcation and the right iliac. And at this time, he had an almost, must say, complete leg ischemia since more than 12 hours. So we discussed what we do, what we then decided, and as always, there are many ways how you can handle such a thing. In this case, we did a kissing stent maneuver. He got a covered stent for the right iliac, an uncovered stent for the left iliac. We landed directly distally to the IMA. And we also, in the completion angiography, we saw that there is an occlusion on at the level of the internal iliac. So he got a self-expanding stent there. The result was not perfect, but at this time the anesthesiologist already asked us to please finish the procedure immediately because it's nearly impossible to keep him stable. So we decided it's okay. He had a pulse at the common femoral artery, so we closed up, sent him to the intensive care unit. I was also on call during the next night, and we had a lot of discussions. We danced around him. The massive hyperkalemia made it very, very hard to recompensate this patient. So for the first time in my career, I considered an amputation because I did not know what to do. It was really massive. The second dialysis machine made it then, fortunately, and the patient was stabilized through the next 2 days. Unfortunately, and that's why this is such a devastating and traumatic case also for me, while we could confirm there was obviously a recent COVID infection during the days before, we found no other reasons for this dissection. He exhibited a brain herniation when they lowered the sedation. So ultimately he deceased, I think one week after we operated on him. So this was really a traumatic and bad case. Let me come back briefly to the question if I think there is any association between the acutely lower or upper limb ischemia and COVID. During the last year, I can remember a lot of patients, among them the elderly gentleman presenting with a dead leg, dead lower limb, and he laid there for 3 days. You all know these cases. We had a lot of the ordinary embolectomy business, and of course, more collateral damage through more intensive care. I just say leg perfusion problems with ECMO or impeller. You all know that. That's our daily business. But when I prepared this this talk, I updated my perspective on the existing literature, and what I found is that there is a clear association between venous thromboembolism and COVID-19, but I was not able to find any hard evidence or good evidence for acute limb ischemia, for peripheral arterial occlusions during that time that is not affected by a heavy selection bias. And I can't say if there is more evidence to suggest more than a prophylactic heparin. but maybe this is up to discussion, and maybe it develops during the next weeks. We don't know. It can be both, but I'm not so sure about all that. So let me conclude. I think that everything is possible with good teamwork. Even the most complex operation can be nice if you have a good team, and vice versa. I think there is a possible relationship between acute lower limb ischemia and COVID, but it appears complex. There are many effects with an impact on that relation. And I think, at least in Germany, the data we used suggests that there are declining admission rates, but a higher in-hospital mortality. And I can't say if there is any higher or at least mid-level evidence to suggest antithrombotics more than for prophylactic reasons. Thank you.
Thank you, Christian. That was an excellent talk, and I think that sort of sums up the flavour of the session altogether. It's that we don't really know is the answer at this point, and more robust evidence or data is required in order to, I guess, coherently change practice individual units.
Yeah,
certainly in the UK at the moment, one of the issues that we're facing with our sort of vaccination policies with the AstraZeneca in particular, although Johnson & Johnson, I understand, has come online now with vaccine-induced thrombosis, is where we stand with the vaccine and thrombotic events. And I've just put a poll up in relation to that to see how many people have actually seen a vaccine-induced thrombotic event. And these aren't people who've had a vaccine and come in with thrombosis, but those, the thrombocytopenic changes and it's almost the hit that you see at the time. And we've certainly seen one and perhaps two in our unit over the last month or two. Talking to some colleagues in the Midlands themselves, they've seen one or two as well. And it's interesting how, to begin with, certainly in the UK, we were perhaps not reporting or under-recognising the phenomenon. I'm just wondering whether or not we've got, such an international faculty here, it's whether or not what we're seeing in America and India, as well as on the European main continent. So if the panelists could give us an idea, starting off with yourself, Christian, have you seen any vaccine-induced thrombotic events?
Personally, not. I have heard from many colleagues, but I think that depends on how you interact with the department or the institution that is responsible for vaccination. And in Hamburg, we have at least 16 hospitals in the area. And if you want to have a population-based insight into vaccination practice in Hamburg, I think you need all of them included in such. That's what I mean. It's always a problem with selection. I can't tell.
Max, anything different from the USA?
Yeah, I would say this is exactly the reason why it's important to have a robust registry. These vaccine clinical trial registries are finding this signal through the noise. And for the J&J, it's less than 1 per million doses, and it may be higher. For the AstraZeneca, it's 4 per million doses. So they're both adenovirus vector vaccines, and they're producing, for some reason, an antibody to platelet factor 4, just like with HIT. But HIT has an incidence of, 5%, up to 5% of people who have received heparin for more than 4 days can develop heparin-induced thrombocytopenia. So that's my take on it.
Shall I ask this slightly? Well, sorry, Robbie, should we get you? What's going on from an Indian perspective?
So don't know, again, just anecdotal data. I've seen the one patient, like I said, which is 2 days back, but we've immunized, probably about 70 million people so far. Yeah, and we're not really seeing huge numbers reported, but then our data collection isn't that reliable. But even on the vascular groups, we haven't heard of that much coming up, no.
Ruth, anything from the West Midlands in the UK?
From our centre, one case with a suspicion, but then most of the people that have come through our doors have had their vaccination because of their demographics. So it's impossible to put a number, but on the chatter, no, nothing.
So I guess another way of asking the question in terms of trying to establish how worried we are is, would we recommend the AstraZeneca or the Johnson & Johnson vaccine to a family member if no alternative was available? Patrick, what would your view be? Sorry, you're on mute, Patrick.
Sorry, I think that's an unfair question. I think Boris Johnson has said that we shouldn't sacrifice our young to the AstraZeneca vaccine. I'll leave it there.
Fair enough, fair enough. So the last poll, just a quick poll, just to bring the poll session to an end, is, given what you've heard today from our 4 excellent talks, do you think this COVID-19 induced acute limb ischemia truly exists, or do we think we're just seeing an artificial signal, as Max said, through a huge amount of noise? So just give that a couple of seconds to run to see what people think. And I suspect what we're seeing there is a true reflection of what vascular surgeons and vascular physicians out the world think, isn't it? I think the majority of us do believe that something does exist, but we're not sure to what extent. Certainly that's the take-home message I've heard from the talks today. Patrick, do you want to pick up on that? You're on mute again, Patrick.
I think we've lost a lot of limbs in our unit, certainly during COVID-19. That's what I'm prepared to say.
Is that more than normal, or?
Yes, definitely, quite depressingly. And I don't know whether to blame it on delays or the severity of the disease that's presenting. It certainly changed the way we work. Yeah.
Okay. I think that's reflected in the talks that we've heard as well, isn't it? Certainly seeing a signal come through. So that's the end of the poll. Thanks to the 4 speakers. I'm going to hand back to Patrick now, who will draw the session to a close. I haven't seen, we got any Q&As? That we have got a fair amount of Q&A come through. Patrick, do you want to address the Q&A? Have we got time for that?
So I think that we've run out of time, but thank you for your questions, and I think that we'll try and type in some of the answers to you. So let's have a look at the questions in. I think we'll take it off screen, offline, the Q&A. But just a reminder to everyone, can you see my screen? Am I screen sharing now?
Yep.
Yeah. So 2 more webinars coming in June this time. So there is the rescuing the iatrogenic vascular injury, very interesting. And also there's one on deep venous sort of early clot removal. Again, brilliant faculty. And don't forget our summer conference. Thank you all for your time. Thank you to the excellent faculty. Thank you to my co-moderator, Rob. Thanks to Ruth. Thanks to Robbie. Thanks to Max, and thanks to Christian for your excellent talks today. And to the audience, don't forget the CPD feedback and CPD forms will be available on email soon. So thank you, everyone, and have a great weekend. Bye-bye.
Thank you all.
Bye.
Bye-bye.